So let's start with our study of non-neoplastic inflammatory orbital diseases. Let's continue with Toulouse-Hunt syndrome. Toulouse-Hunt syndrome is a non-granulomatous reaction that involves the superior orbital fissure, the cavernous sinus, and the orbital apex. So if you have a granulomatous reaction that involves these three entities, then that would be classified as a Toulouse-Hunt syndrome. As is understood, there are multiple cranial nerves that go through these structures, specifically the cavernous sinus. So you are bound to see a multiple cranial nerve palsy. So that would result in a hemicranial pain. Proptosis might be mild, sensory loss along the distribution of the first and the second division of the trigeminal nerve. Systemic steroids and immunosuppressants as necessary. So now let's look at how the patient presents with in a general presentation of a Toulouse-Hunt. A healthy patient presents with complaining of a painful double vision. So you have pain and you have diplopia. Examination would reveal a normal visual acuity but diminished corneal sensations. So diminished corneal sensations is your star keyword. You're supposed to keep this in mind. There's a global impairment of ocular motility in the left eye with no proptosis. There is pain with eye movements and the globe and orbit are slightly tender. Computed tomography and MRI are both normal, and patient rapidly and completely responds to a 60 mg of oral prednisone a day. So he's a good steroid responder. There is diminished corneal sensation and there is a painful double vision. So the diplopia and pain is present and the patient is otherwise healthy. So these are all of your keywords that can sort of guide you towards Toulouse-Hunt. Now let's look at the answer. The answer is obviously Toulouse-Hunt syndrome. It is thought to be caused due to a non-specific inflammatory process of the cavernous sinus. It can also include the superior orbital fissure and the orbital apex. Some findings include painful ophthalmoplegia, particularly to be concerned with the first, second, and the fifth trigeminal nerve, and then sensory deficits of the trigeminal nerve, most commonly of the ophthalmic division. So this is what we wanted to concentrate on. And the dramatic response to systemic corticosteroid therapy would be your third clue. Remissions may be spontaneous with partial or complete reversal of deficits. Episodic recurrences can occur, and aneurysms of the circle of Willis can also produce a similar picture, including the steroid responsiveness, but they would not have a normal MRI. They would have a normal MRI with a very small chance of a normal MRI. So that makes Toulouse-Hunt syndrome a diagnosis of exclusion. So let's move on. Now let's look at Wegener's granulomatosis. It's a multi-system granuloma reaction that also occurs in the orbit. So Wegener's granulomatosis is not just happening in the orbit, but it's a multi-system disease that also happens to manifest itself in the orbit. So let's look at how does it manifest itself in the orbit. It's generally spread from paranasal sinuses. It has bilateral inflammation with sinus pathology. You should consider a Wegener's granulomatosis. So you have a bilateral inflammation and you have a sinus pathology, then consider a Wegener's granulomatosis with that. So if you have a sinus pathology with a bilateral inflammation with no other signs of an orbital cellulitis or something else, then you can go for a Wegener's granulomatosis. Some definitive diagnostic features are C. ANCA, a scleritis, peripheral ulcerative keratitis, and a retinal venous occlusion. These also respond well to immunosuppressants and steroids. Now, proptosis should be considered in any patient with bilateral orbital inflammation. Then you definitely will have a serological test positive for C. ANCA. And other features such as scleritis, PUK, and RVOs might accompany. Treatment, you might give a cyclophosphamide and steroids. In a resistant case, you might use cyclosporin, azathioprine, antithymocyte globulin, or plasmapheresis. Surgical decompression may help if you have a severe orbital involvement. Now let's continue. We have a fistula that is forming between a carotid artery and a cavernous sinus. So what happens is the venous pressure rises because there is a lot of pressure in the cavernous. There is a lot of pressure in the carotid artery. It would eventually cause the pressure in the cavernous sinus to increase. It would give rise to an episcleral venous pressure increase, and whereas the arterial blood flow would decrease. There could be a direct fistula or there could be an indirect. A direct fistula would be a high flow shunt. This could be due to a trauma to a carotid artery, where the carotid artery directly goes into the cavernous sinus. Then with an indirect dural shunt, you can talk about a cavernous sinus with an indirect dural shunt, you can talk about a cavernous part of the carotid artery is intact, but blood enters into the cavernous sinus from meningeal arteries. So the part of the carotid artery that is near the cavernous sinus is intact, yet you see there is a lot of inflow into the cavernous sinus from meningeal artery. So that would be called as an indirect dural shunt in carotid cavernous fistula, and this is more subtle than direct for obvious reasons. Now, looking at the diagram we have here, this is how CCF presents normally. So let's look at what sort of symptoms and signs are we looking at. A diagnosis for a direct carotico-cavernous fistula would be, it would be post a head injury presentation. This is a key point. It might be weeks before or days before. Then you have a gradual redness due to conjunctival vessel engorgement. So there is gradual redness due to conjunctival vessel engorgement since the pressure in the epicleral veins have increased. Then you have a sudden vision loss due to optic nerve damage and head injury. So you might have an accompanying vision loss also. Marked epibulbar vascular dilation. This is another key point. Then you will have a pulsatile proptosis with a bruit. Another very important key point. So pulsatile proptosis would mean that there is a lot of pressure that is being built up in the eye, and because of that pressure from behind, the veins that are connecting to the eye are sort of pulsating. They're pulsating because they have blood coming from the carotid artery. So what this causes is, it causes a to and fro motion of the eye, and this is almost microscopic. We won't be able to see with your naked eye. You need to use a slit lamp. So, and also not just using a slit lamp will get you. You need to use your applanation tonometer, as you would do normally to check the tonometry or to check the IOP reading. You put the applanation tonometer flush on the patient's cornea, and if you see pulsating Myers are nothing but basically two kinds of Myers that are basically what you see during your tonometry measurements, but they tend to change sizes. They become big and then they become small again. So if you see a pulsation of these two Myers, then you might understand that this could be an eye that is sort of bobbing due to pressure from behind. Now, continuing. There is an obvious increased IOP due to an episcleral venous pressure. Then you will have a corneal edema due to an anterior segment ischemia. An anterior segment ischemia could be due to the carotid artery forming a fistula, and there is decreased arterial pressure, because of which there is not proper blood supply to the anterior part of the eye, which results in an anterior segment ischemia. Continuing, you might see a ptosis due to a third nerve involvement, and ophthalmoplegia that is seen in 70% of cases. Then it's again a key feature to be noted. You have a sixth cranial nerve involvement. Disc swelling also, since there is a increased pressure from behind. Now, how do you diagnose an indirect carotid cavernous fistula? You look for mild epibulbar dilatation, milder relatively as compared to a direct shunt, very strong pulsations but no proptosis. So the pulsations might be very strong, but there is virtually no proptosis. You look for corkscrew vessels. I'll just show you what corkscrew vessels are in a while. IOP will definitely be increased. You will look at for mild ophthalmoplegia. So everything is a little bit milder over here. So let's look at this diagram of a typical presentation. Now there are two key features that are being represented here. First, you look for there is conjunctival injection. That means the conjunctival vessels have been engorged and dilated due to an increase in the episcleral venous pressure, and then there is an epibulbar dilation, which basically means the same thing. And then you have a corkscrew pattern of vessels that is seen again due to an increased episcleral venous pressure. So then moving on, some further investigations that you might want to get done are a CT and an MRI. and you look for a superior ophthalmic vein prominence, and this is due to an increased episcleral venous pressure. So you also look for an extraocular muscle enlargement, and a CT and MRI angiography might also help. A neuro opinion is mandatory since these people are at an early risk of a stroke. Now, for a direct CCF, it's not life-threatening, but the eye is definitely a risk, so you need to keep that in mind. And a post-traumatic fistula closes spontaneously, so you need to keep that in mind as well. Repair the artery or occlude the sinus will be your primary way of dealing with a fistula, and you use a coil or a balloon embolization via craniotomy surgery. Now, an indirect carotidocavernous fistula would involve a transvenous occlusion of the involved sinus, and a spontaneous closure might be seen in 50% of CCF indirect patients. So this is the cavernous sinus, and this is the superior ophthalmic vein. And now here you have used a coil to sort of occlude the sinus and treat the CCF. So in these radiology images, what you are looking for is an enlarged superior ophthalmic vein. This is how it is. This view is from the top, and then these enlarged muscles are the extraocular muscles of the eye. So they are thickened, and that will help you in diagnosing with a CCF. So we've already gone through these diagrams before. So this is basically epibulbar dilatation, conjunctival injection, and then you have a very severe sort of a conjunctival injection that would guide you towards diagnosing it as a direct carotidocavernous fistula. And this is how a hemorrhagic chemosis looks. So chemosis is basically a conjunctival edema, and here you have blood that fills up these things, and you can see how they are bulging out of the eye. Looks pretty painful to me. Now, a moderate cavernous fistula will have a fundus presentation as follows. Here you are looking at a lot of dot and dot hemorrhages, and I can see there is a mild disc swelling also. Now moving on, this is a milder form of a venous dilatation, and this could be an indirect carotidocavernous fistula. This is a typical corkscrew pattern that is seen over here. That is again a key feature of the CCF. And then this is a retinal. So now let's look at some presentations for CCF. A 28-year-old man presents to an ophthalmologist 1 week after being in a motor vehicle accident. So this is possibly a post-head injury patient with a resultant blunt head trauma. He complains of irritation and redness of the left eye. This could be your conjunctival injection. Vascular visual acuity is normal bilaterally. There is marked conjunctival infection in the left eye with prominence of the superficial and deep vessels all the way to the limbs. This is your biggest keyword that is thrown into the question. There is 5 mm of proptosis in the involved side. Slit lamp examination is normal. Intraocular pressures are 16 and 25 mm in the left eye. So the left eye has a slightly increased IOP. Fundoscopic examination is normal on the right, but it's normal on the right, but reveals dilated, tortuous retinal veins on the left. So that is another clue for you that this retinal tortuosity is because of a CCF. Now on careful questioning, the patient reports hearing a rushing noise. So this rushing noise intermittently could be a bruit. That is a keyword again that is thrown. Now auscultation of the left orbit reveals a faint bruit. So I didn't tell you guys this, but you're supposed to use the bell of the diaphragm, basically the bell of the stethoscope, the smaller part, to check for bruits. Okay, I'm sure there's a YouTube video around how to do it, but just have a look at it. So you're supposed to auscultate the left orbit, and that reveals a faint bruit, so it is confirmed. And then arterialization of his orbit is most likely caused by a disturbance. And so the question is not asking you to diagnose it directly. He expects you that you have already diagnosed it by all these keywords. Now what he's asking you is the underlying mechanism of what is happening here. Now he is already assuming that you understand that there is an arterialization that is happening here, and the arterialization he's asking you the cause for it. So let's look at it. This would be a classical presentation for an internal carotid-cavernous fistula, often resulting from the shearing effect of a rapid acceleration or deceleration trauma on the relatively fixed immobile artery passing through the sinus. So the arterialization of his orbit, the reason could be there's a fistula in between the cavernous sinus and the carotid artery. That would be your answer. Let's look at another presentation. A 73-year-old woman, she's relatively old. So presents to the ophthalmologist complaining of mild redness and irritation to the left eye for approximately 2 months. So there is mild redness and irritation. It is milder. She denies any head trauma. So there is no head trauma. So you need to get the post-head injury direct cavernous CCF out of the diagnosis. Visual acuity is normal bilaterally. There is 3 mm of proptosis on the left with mild tortuosity of the retinal vasculature. So there is tortuosity. There is a mild proptosis in the left eye, and there is an increased IOP, that is 12 mm Hg in the oculus dexter, that is the right eye, and 30 mm Hg. So there is an increased IOP in the right eye, whereas the left eye has proptosis 3 mm. So now, what is the cause of the arterialization in this patient's orbit? Again, I would say it's an intracavernous internal carotid artery, or it could be the branches of the middle meningeal artery. The answer is E. So this is in contrast to the previous question, a classic presentation of the cavernous sinus dural wall shunt featuring low arterial flow and a more insidious onset. So as you can remember, an indirect carotid cavernous fistula will involve a meningeal arteries, and that is how the shunts are formed. In low flow fistula, the head trauma may be only minor. More significant head trauma is the more frequent cause of high flow cavernous fistula or direct cavernous fistula. Almost 75% of post-head injury cases will have a direct CCF. Spontaneous rupture caused by hypertension or atherosclerosis is the cause in most of the remaining cases. So spontaneous rupture that is caused by hypertension or atherosclerosis is cause of most of the remaining cases. So a high CCF, high flow CCF, 75% of the time it would be a post-head injury, and the remaining 25% of the time for a high flow CCF would be an atherosclerosis and hypertension. Studies have documented that up to 80% of patients with cavernous sinus dural fistula will develop ocular hypertension, 25% of patients will develop optic disc cupping, and 20% will develop visual field defects. Any entity that raises episcleral pressure can cause secondary open-angle glaucoma. Okay. So iris and posterior segment neovascularization as well as rapidly progressive cataract may all be seen as complications of the ischemic oculopathy that these fistulae generate. Corneal exposure caused by proptosis is another potential complication of carotid cavernous fistula. These fistulae could be an ischemic oculopathy, a rapidly progressive cataract, and a posterior segment neovascularization along with an iris neovascularization. So corneal exposure with Batman due to proptosis are all potential complications for a CCF. Neoplastic vascular abnormalities, starting with cavernous sinus thrombosis, clotting within the cavernous sinus because of sinusitis, orbital cellulitis, or otitis media, which causes 20% of people to die. So there's a clotting in the cavernous sinus that could be due to an orbital cellulitis, an otitis media, or a sinusitis. So these can cause a clotting in the cavernous sinus, and 20% of people die. It has a rapid onset, severe headache, and proptosis due to increased pressure from behind. Chemosis again, and congestion of the eyeball and face. There might be an involvement of the third and the sixth nerve palsy. MRI and lumbar puncture are also seen. Now, IV antibiotics and surgical drainage might help. So guys, you did a great job sticking till the end of the video, and that means I get to tell you all about the stamp for this video. It's the 21st International Ophthalmology Congress stamp with the diagram of the human eye on the left side, and with the beautiful Italian stamp commemorating the 25th International Ophthalmology Congress. As you know, ophthalmology stamps are my thing, and every time you finish a video, you get to discover a new stamp. So keep watching all my videos till the end.
Guys, if you like this channel, please consider subscribing and sharing this channel amongst your friends, your medical students, medical graduates, undergraduates, postgraduates, the like of them. And if you like my content, please consider liking it, and please do leave a comment. I read all your comments, and all and any feedback is welcome. This is part of the revision series that I just wanted to do since I wanted to prepare for my exams. I hope these help you out too. Thank you.